Hello, I'm Dr. Paul Martin. I'm a family physician and a specialist in addiction medicine and occupational medicine, and I'm here today to talk about office-based urine drug screening. Over the past several years, we've been in the midst of a prescription drug epidemic, and there's been a strong move to help physicians prescribe more safely. Office-based urine drug screening is just one tool that will help you prescribe more safely to your patients. This project, Lazarus Clinical Trainings, was sponsored by Community Care of North Carolina, Mountain AHEC, and supported by a grant of CMS through the Integrated Chronic Pain Project. Over the past decade, the incidence of unintentional poisoning deaths has catapulted in North Carolina and indeed across the nation. In 2010, the number of unintentional poisoning deaths exceeded the number of deaths in motor vehicle accidents for the first time. And far and away, the majority of these poisoning deaths are coming from prescription opiates. Project Lazarus is just one of many campaigns to help safer prescribing of controlled substances, specifically narcotics, and is undertaken through community-based coalitions, clinical trainings, and evaluations. When we speak of urine drug testing, there are two great classes of drug screening. One is for employment testing, such as CDL drivers or safety-sensitive positions, and therapeutic screening, such as in everyday medical practice. We are going to be talking specifically about the use of urine drug screening in the therapeutic sense. So the question is, why are we drug screening? What tests are available? And then the differences between those tests that you can do in your office, known as point-of-care screening, and the tests that we see when we send off to certified labs, that is confirmation testing. These three areas will be discussed in part 1 of our series. Part 2 will go on and discuss the practical and tactical considerations of urine drug screening. So why are we screening today? Well, we're screening to protect the patient, especially the patient who may be taking medications that you're not aware of and may interact with the prescriptions that you are prescribing. We certainly want to protect the public. We know that we're in the midst of a prescription drug epidemic, and we want to protect the physician's license against illicit diversion and prescribing that might get the physician into trouble. The Federation of State Medical Boards published a policy in July of 2013 about the use of opioid analgesics in the treatment of chronic non-malignant pain. Part of their recommendations was that physicians needed to do more monitoring of patients who were receiving prescription narcotics. The North Carolina Medical Board came out with its own policy for the use of opiates in June of 2014, and again, they realized that chronic pain is probably undertreated, but there was a need to protect the public, protect the patient, and protect the physician by doing more monitoring. So the monitoring doesn't just include periodic drug screening. Monitoring includes discussion with the patient about their quality of life on medication, whether or not they're adhering to the medication and other plan for improving their well-being, and whether there's aberrant behaviors. We also rely on family members to provide information about the patient and the patient's proper use of medications. In North Carolina, we have a controlled substance reporting system, the CSRS, that any licensed prescriber can access and should access prior to prescribing chronic controlled substances. We can assure that the patient is taking their medicine by simply having them bring their medication in during the visit and count the pills. If the patient is seeing either a therapist for psychological reasons or a therapist for treatment of an underlying addiction, discussion with that therapist should be part of the documented monitoring. And then finally, we have periodic drug screening. There are several different drug tests available today. Certainly, saliva, hair, sweat, blood, and urine are all available. But for a number of reasons, urine drug screening is the best for therapeutic screening in practice because of cost considerations and because of the window of opportunity to review the use of drugs. Looking at this chart, we can see that urine will reveal any drugs that have been used in the past several days, whereas hair may give you the past several months. The difficulty with blood is that, number one, the tests are very expensive, and number two, they aren't nearly as sensitive as the urine drug testing. Most of us have seen the multi-drug test cup that is intended to be used in point-of-care testing situations. These are immunoassay-based tests. They're antibodies that typically are targeted for a specific class of drugs. They also are targeting a specific level of drug, and if the drug is below that cutoff or that threshold, the test is negative. So it's important to understand that even though the test is negative, the individual may have used one of the medications or drugs, but it's at a very, very low level. The other important thing to remember about office-based urine drug testing is to make sure that yours is CLIA waivered. These CLIA waivered tests cost between $4 and $8 for multi-panel tests and don't require nearly the documentation and paperwork that a CLIA unwaivered test would have. So simply look for that CLIA waivered test when you're purchasing a kit for your office. Confirmation testing, generally done at laboratories, look for very specific compounds and are used when there's doubt about the results of a office-based urine drug test. These tests have much better sensitivity even though their cutoff level is not 0. It's generally lower than the cutoff levels that we saw in the office-based tests. These confirmation tests cost between $100 and $150 per panel and should not be used for office-based screening unless there is a specific question about a result. That brings us to the end of Part 1. Part 2 will continue with tactical and practical considerations of urine drug testing.